This is the Whole Care Network. Helping you tell your story one podcast at a time. Content presented in the following podcast is for information purposes only. Views and opinions expressed in this podcast are solely those of the host and guest and may not represent the views and opinions of the Whole Care Network. Always consult with your physician for any medical advice, and always consult with your attorney for any legal advice. And thank you for listening to the Whole Care Network.
As hard as that bereavement experience and grief and loss was, I felt so supported by my colleagues. That being said, it's much different than when I came back and had to sit in front of families while I'm grieving also a loss and I'm helping other people loss. One of the things about hospice work is, and even helping anyone in general, is when we help others people, we get something in return.
This is the Heart of Hospice podcast with Helen Bauer. My guest, Melanie McMillion, has years of experience as a hospice counselor and community educator. Whether you're a family caregiver or an end-of-life professional, the Heart of Hospice is here to enhance your hospice experience by connecting you with information you can use about end-of-life care.
Today's episode is sponsored by Odonata Care. Odonata's motto is, "Care is treatment." They have a mission to transform the end-of-life experience for the patient and caregivers through education and support. Odonata Care is revolutionizing the hospice experience with their booklet, The Care Plan, A Path to Comfort for the Hospice Patient, along with 50 free YouTube videos that teach the basics of bedside care. Visit thecareplan.net for more information. Now, here's today's episode.
I could have talked for another couple of hours with my guest today, Melanie McMillion. Melanie is a licensed mental health counselor, and she's got years of experience working in hospice care. And you're going to hear her story and the work that she did, the ages that she was when she was working in hospice. She's worked as a counselor in hospice as well as a director of psychosocial, spiritual, and bereavement services. She's worn a lot of hats. Melanie also moved into an education position where she worked as an external educator, speaking out in her community to provide education and information about end-of-life care. So she knows a lot of things about hospice because she's seen a lot of things in hospice. So we are talking about everything from interdisciplinary teams to bereavement care. You're going to love this conversation. It's chock full of information today. So here's my conversation with Melanie McMillion. Melanie, thanks so much for being on the podcast. Welcome.
Thank you so much. I'm happy to be here.
So to get us started, we're just going to chat a little bit. I got an icebreaker question.
Okay.
Tell me, what is one of your biggest pet peeves? And only one.
Oh, gosh. Well, the people that know me will say I'm a pretty easygoing, laid-back person. So I tend to let pet peeves roll off my shoulders and back and just keep it moving. But probably one that really triggers me is when people throw trash outside their car window.
Oh, wow.
I don't know why, but that is just like, the world is not your trash. That's something that just really bothers me.
Oh, I think I would add that one to my list too. That's a good one. Oh, wow. Okay. I feel a little irate. That's awesome.
Exactly.
Okay, so Melanie, you have years of experience. I don't want to make you sound old, but you got a lot of time in end-of-life care working in hospice, which is awesome. We could talk for a month about all the different things and different aspects of hospice that you've worked in and been involved in. So in your time in hospice, how did you see it evolve? How did you see end-of-life care change during your years in hospice?
You know, when I was thinking about that question, one of the first things that came to me is I remember back when I started in hospice. And for those that want to know my age, I have no problem saying I started when I was 26 and I'm now 54. No shame here. Well, actually, I'll be 54 in August. But there was a time when National Hospice Organization was just that, National Hospice Organization. And then they decided to become National Hospice Palliative Care Organization. And I can remember at that time, us hospice people on the front line, we were angry. We were mad that they were going to put this palliative care word in there. That, we shouldn't be ashamed of hospice, and some of the feedback would be like, well, people don't like that hospice word. We were like the hospice flag people. Like, this hospice is beautiful. It's wonderful. It's amazing. We don't want this palliative care piece with us. We don't want them. And over time, obviously, I'm very grateful we have palliative care with us, hospice and palliative care. And one of my wise medical directors said to me once, all people on hospice are receiving palliative care, but not all palliative care people need hospice. And that really resonated with me. So I feel that may sound small, but that was a significant change of opening up the skill set of our team, our interdisciplinary team, to help people that weren't ready to qualify for hospice. But it also, I feel, allowed people to say, well, my loved one's on palliative care, even though behind the scenes we're all like, it's hospice, because we love hospice.
I can totally understand that response, though, because the model was so great. Right. And we have changed as an industry. What you're talking about happened even before my time in hospice. And I've been in hospice about 14 years or so. But we didn't want the model to change. I hear from these workers that have been doing this 30, 40 years, like Barbara Carnes, and she'll tell you, this is not how we started out. This is not what we looked like. We were, for one thing, they were manned by volunteers, and now we're super heavy on the for-profit hospice agency side. So definitely changed. I can see how people would want that, but your hospice doctor was super smart. All hospice contains palliative care, but not all palliative care is hospice.
Yes.
That's the way it was explained to me. And I think it makes good sense when you hear it put that way. So in this time that you've worked, you worked as an educator out in the community. You were supervising psychosocial and spiritual and bereavement professionals. So you were working with chaplains, social workers, bereavement coordinators, or bereavement counselors. That's a big mixed bag. These folks have a tendency to be the stepchildren of the hospice team. And I think nurses make it worse. As a recovering nurse, I will say that we have a tendency to think that nurses are the end all be all, that the medical and medical nursing care is the most important thing. How were you an advocate for your social workers and your chaplains?
Well, I think that it starts with my own experience. And I think I was just lucky when I started in hospice services and hospice care. I worked for a smaller hospice and very big on the interdisciplinary team or patient care team. That changes over time too, what we call all of us.
Right.
But I was kind of, when I started it, I didn't feel like a second outsider of the team because the way the hospice was organized, we were very much a valued part of the team. And so I think as hospices get bigger and they grow and they have more people, obviously, I think that's when that can become siloed. But I can remember when I was back in the 90s, when I went to a conference, there were tons of workshops on spiritual care team feeling like the outlier, the social work team feeling like the outlier, the bereavement team. So it really comes with why the hospice benefit works so well is that each discipline is just as important. So an example may be a family member spends a lot of time with the CNA, and they get to know the CNA, and the CNA becomes the closest person, but the CNA may not be trained on how to manage the family's emotional. And then you would come in. And so as the social worker or the counselor, you're helping other team members navigate the case, even if you're maybe not even, the family says, oh, I don't want, a lot of people reject this, so I don't need counseling, I don't want the social worker. So the team can be very important helping the medical staff navigate through the patient's care.
That's absolutely true. Absolutely true. And I think when it comes down to it, we have a tendency to, as a team, an interdisciplinary team, to forget that even if the family or caregivers and the patients say, we don't want the chaplain visits or we don't want the social worker visits, that doesn't mean we are not responsible for their psychosocial and their spiritual health.
Yes.
And I think we have a tendency to forget that, if they don't want the chaplain, then we don't have to worry about that particular portion of their humanity.
Right.
And that's not true.
And I also think on that same point, it's important for, if you have for nurses in the audience listening, or medical care team, or the CNA even, I always tell them, don't feel like you have to do my role. It's okay if the family has bonded with you, but it's important for you to say, I know Melanie. Melanie is a great social worker, because they trust you. And so you're going to open the door for them to allow me to come in. And I know you trust me. So when I get there, because if the nurse and the CNA or the medical team are the only ones doing all the other part, they're going to burn out. They're going to have that compassion fatigue. I know we're going to talk about in a little bit. So you have to be careful. That's a slippery slope. So it's really important to say, you know what, I know you haven't wanted, let's say the patient's talking about a spiritual struggle. Why is God doing this to me? That's a perfect opportunity to say, I know our spiritual care chaplain, I know he would be a great person to come in and maybe help facilitate that.
Right, right. I think we forget about that. There's a little bit of convenience. We're already taking good care, maybe a little bit of arrogance. We already got this, right?
Yeah.
But I think at some point there's going to come a slip up, because there will be a need presented that we cannot meet because we're not qualified.
Right.
Nurses are not chaplains. Nurses are not social workers. And my gosh, I've never met a hospice nurse that had time to be all of those different disciplines.
Yes.
Never, right? They are so busy these days. So let's change topics just a little bit. I want to talk about the team. We do have a really unique model for the team. You were talking about it, an interdisciplinary team or an interdisciplinary group. Those two terms are really interchangeable.
Mm-hmm.
But basically what it says is there's not a hierarchy with the physician at the top and then the nurse and then listing the other disciplines with the CNA at the bottom. It doesn't work that way in hospice. It's a lateral relationship. Lateral hierarchy is not even the word for it. There's a mutual sharing of the responsibilities, all based on the skills that each of us brings to be able to take care of the patient and the caregivers, which is amazing, right?
Amazing.
Yeah. I don't know that there's another silo of healthcare that uses this particular model, but it really is very unique and very effective.
Mm-hmm.
But we are affected very differently by the work that we do as well. We experience a lot of secondary grief, and in addition to burnout, that's two different things, right? But the secondary grief we experience is profound at times. It affects us very intensely sometimes. In your experience, how does that secondary grief that we experience as end-of-life workers affect the different disciplines on the team?
I thought about that question, and I feel like I don't think it's specific to what your role is, in the sense of more of how much time you spent with the patient, how much opportunity you had to connect with the client or maybe the family, that impacts how that secondary loss is going to affect you. One of the things when I first started in hospice, I worked I was a counselor that was on a team with dying children. And obviously dying children is a unique part of hospice that not all people can, or even will say, I can do good work with that population of a child dying and working with families. So when I had my own children, because you guys heard in the beginning, I grew up in hospice. When I had my own children, that was the time I had to switch and go to my supervisor and say, I notice I'm having a lot of transference for the therapists in the audience, that I keep thinking about my own kid. I'm not doing good work and I need to switch to another team. I want to switch to a different kind of caseload. And they responded and said, we understand that, I'm good at what I do, but they really honored where I was at. So I feel there is, for all disciplines, no matter what role you're in, the thing is you have to stay close to your supervisors, your directors, people that you trust to help you navigate when you notice. And that's what I love about the interdisciplinary team, because it could be your chaplain that comes to you and says, Melanie, I kind of notice that you're quiet, you're not really, and that's why this model is so amazing, because it takes all of us to be able to provide the best care.
Absolutely true.
This episode is sponsored by Odonata Care. Odonata Care founders Nancy Hireman and Brenda Kazire have crafted a 32-page booklet called The Care Plan, A Path to Comfort for the Hospice Patient. Here's what certified hospice and palliative care nurse Helen Bauer says about the Odonata Care booklet.
As an end-of-life educator and advocate, I'm always on the lookout for great resources to share with caregivers and anyone dealing with a serious illness. The Care Plan from Odonata Care has features that users can access anytime they need it. There's information about the symptoms we commonly manage at end of life, like pain, anxiety, shortness of breath, and secretions. Caregivers can use the Care Plan's tracking forms for medications and write down specific instructions for their loved ones. There's even a section on how to use meds safely and appropriately. The Care Plan from Odonata Care is the perfect bedside resource for caregivers.
You can purchase copies of the Care Plan for yourself or your hospice agency at thecareplan.net. Also, watch for their new Spanish version coming soon to their online store. Now, back to today's episode.
So I want to touch back on something you said about it's not so much related to the roles that each discipline has, but how intimately we get to know a family and become immersed in the care life of that family. So let's talk about CNAs.
Yes.
Man, they are the workhorses of the interdisciplinary team, and they have the most frequent contact. But I wonder, when you think about how they process secondary grief, do we really support them well?
I would say that's probably an area that, as you said, we're all busy. We got the next patient. We got to, we have our own families we have to get to, and that kind of probably gets pushed more to the side. And that's where it comes back to your team meeting, where you can incorporate an opportunity there to read the patients that have passed their names and allow a few moments for team members to share about the patient or the family, funny stories, kind of anything just to kind of reminisce. I know some care patient units have like memory boards or areas where you can put things. So it may sound like a Band-Aid, like memorial on the fly, but those things are all helpful just to acknowledge that someone's life mattered. At our one of the units I worked on, when a patient died, we would put a butterfly in the door just so that everyone would know the patient died. We could all say words. It was a way we could communicate, but we weren't sitting down really having dialogue, but it was your way internally to kind of allow yourself to process that patient had passed.
I think those things are important, because if an interdisciplinary team only meets every 2 weeks, and that's the first time you have an opportunity, do you hold that? that secondary grief until you get to that interdisciplinary team meeting. The other thing is our aides are not typically involved in our team meetings. Most agencies do not bring their aides in to sit in the IDT meetings.
That's true.
Which I think could be a mistake. May not be the best thing.
Mm-hmm. I think that's where in the old days they did. In the old days, our CNAs did come to our meetings. But I know today that's another area where things have changed.
Well, a lot of that goes back to productivity. Because if you bring them in out of the field and they're not seeing patients to give them their baths, manage their personal care, then they're in the office, but you're paying them for their time to sit in the office and participate in this meeting. So I can see, people look at productivity for that. I think the way we support each other on an interdisciplinary team helps us not only manage our secondary grief, but it bonds us as a team. And I think it's very unhealthy to silo out and sort of alienate any one discipline. I think medical directors are an example of that because a lot of medical directors are part-time workers for the hospice agency. They come in for a 2-hour meeting and they're out. And that's it. Yeah, they have contact with the clinical team when the team has questions about medications and treatments and wound care and things like that. But other than that, they come in for a 2-hour outpouring of what's happening with patients, and then they have to go back. And our aides don't even have that much. So it's really no wonder we struggle with secondary grief going from patient to patient.
Mm-hmm. Some hospice teams have like an example of a nursing home team where the team only goes to nursing homes, the team goes to homes, or the team goes to ALFs, and everyone does it. And then you also have, obviously the inpatient. So an example of the nursing home team, many times those aides are in one facility taking care of 15 patients, right? So that could be an example where if you have a good relationship, I'm thinking back when I was an educator, I could go to the nursing home if we knew we had several losses and we could do something there with the staff there at the nursing home, but also we'd include our staff. So there are ways you can be creative to create opportunity for just to be together and recognize what we do is so hard, but so amazing, and also acknowledge the people that have passed on. So you can be creative and use other people on your team to help create those type of, even your chaplains can come and do maybe just a 15-minute memorial or gathering of people and to allow to have some processing. But the biggest thing, like you said, is that we're all in it together. So if I'm coming down the hallway and you're crying or upset, we have a relationship, a connection to say, you want to go in the back room and talk.
Right. It's easier to support each other. People are more open to it. What you're describing would be so validating. I see the work that you've done. I see the connection in the relationship and the part of you that you invested in the care of this patient, not just the skills, but the part of your heart and the humanity that you bring to the care of your patients and their families. So let's take a minute and acknowledge that this happened to you and with you. Not just because those losses don't just happen to our caregivers. They happen to us as well.
Thank you.
So when it comes to managing personal losses, right? Mm-hmm. Hospice professionals, why we got the cape and we're flying the invisible plane. And so we just breeze through every patient and take care of them and keep on moving until we have our own personal loss. Do you think we manage personal loss differently as hospice end-of-life workers?
Well, for myself, and I wanted to share my own experience. When I was just 2 years into hospice, my mom was diagnosed with a very acute cancer diagnosis and lived maybe 2 months, and she was a week on hospice and died. I was 26 years old when that happened. And at that time, I had the knowledge of hospice, so I was able to help my mom navigate a huge system with my family in complete chaos and trauma. But I want to say this. The hospice, my coworkers were the most amazing, loving people that helped my family and us navigate. Now, she was in a different town, so I was leaving, going out, but the team would be calling the hospice over there. I felt like I had this like 50 people. It was amazing. As hard as that bereavement experience and grief and loss was, I felt so supported by my colleagues because they understood, they knew it was like I was navigating. That being said, it's much different than when I came back and had to sit in front of families while I'm grieving also a loss and I'm helping other people loss. One of the things about hospice work is, and even helping anyone in general, is when we help others people, we get something in return, right?
Always.
And so even when you're grieving, I would find it as amazing. I don't know, it would be like really bizarre. I'd be helping another family and it would make me feel better. But I also had to be very careful to keep that in check. So I had my own counselor outside of hospice, right? I made sure I had my own place. I had my own spiritual care team that I could talk to. It required a lot of awareness and understanding that I always had to keep it in check, that I wasn't making it about me and using it in a healthy way. Because I've had to hire staff, I always find it interesting about hiring people that come to hospice. And you know this, Helen, because you've been doing this a long time. A lot of people come to hospice because of a loss experience, either positive or negative. When you interview people, they'll say, I had such a wonderful time experience, especially our volunteers. Most of our volunteers have had a personal story.
Right.
They'll say, I had a really personal, and I loved hospice. I knew this is where I want to be. Or you'll sometimes have the opposite. They had a horrible death experience and they wanted to come to hospice to make it better. In that same vein, I've had many staff that leave hospice because they've had a loss, because it's hard to navigate it. So loss is universal. We all experience loss. It doesn't matter if you work at hospice. Doesn't mean, hey, you work at hospice, you get off the loss checklists. You're not going to experience it. No. So it's still part of life. It's still something we all have to navigate. And when people have chosen to leave the work because of a loss, I always tell them you have to honor where you're at. And if it's too much for you, you're not doing good for yourself, number one, but you're not helping anyone else on the other side. I also kind of want to stay with my own story because I want to fast forward. My father died in 2010. My dad I lost to a heart attack, very sudden. It wasn't a hospice experience. It was a sudden, one day you get the phone call and then boom, I had this acute loss of my father. At that time, I chose to take a break. I left hospice when my dad died to settle his estate, to take care of those family things. And I was away from hospice for about 6 months, just caring for myself, my family, my extended family. And then that's when I came back as an educator, because when I came back, I said, I feel like I don't want to do patient care right now. I love hospice, but I know that wouldn't be the right space for me. And then I came back as an educator. I worked a lot in bereavement. So I want the audience to know, if hospice is your calling, there are always places for you to be. And not always try to say, I have to fit in this one box and this is all I can do. I mean, hospice, there are so many other avenues of doing the work. Why you take care of yourself?
Yeah, that is such an important thing for people to hear. Such an important thing. When you're going through your own loss and you encounter a patient and a family where it's very relatable, mm-hmm. that you can no longer keep the boundaries that you were just talking about. Mm-hmm. It's not healthy for you. It no longer is healthy and safe for the patient and the family either.
Right.
That is the time to be self-aware enough to go to your supervisor and say, I can't be in this space. It's not a healthy place for me to work in, but I'd like to be somewhere else. Yeah, and I think it's so easy to relate to so many different situations. My experience of overly relating to someone didn't actually happen related to a personal loss. It was the weirdest thing. So as I aged as a hospice nurse, I was mostly caring for older people, right, who were the age of my grandparents, 40, 50 years older than I was. But as I got older, I ended up encountering patients that were closer to my age. And that for me was very relatable, very relatable. And I connected with it enough that I had a little meltdown, realized I needed a lot of self-care, but it was the death of a patient that I had never seen before. Mm-hmm. I didn't even do his death visit. I saw him while he was actively dying, and he was my age. And he had an older teenage son, about the same age as my kids. And somehow that clicked in very heavily with me.
Yes.
And I think you relate to those losses. You relate to something about that person. This woman looks like my grandmother. This person is my mother's age. Mm-hmm. That kind of thing. And I think it's very easy for those boundaries to get blurred. I want to ask you something, Melanie, and I don't know if when your mother died, if they had bereavement structured the way it is now. But did you participate in the bereavement program that the hospice agency offered? And was it meaningful for you?
That's a great question. When my mom died, obviously my dad was still alive. We immediately called, this is for all the adult children out there, called the bereavement department for my father. He needed services. And the bereavement counselor came out to the house. And like I said, I didn't live where my dad lived. But the first session, he said to the bereavement counselor, my wish is to tell my daughters that I don't need them to be the parent. So,
that was some boundary setting there for you.
Yeah. So my father, yes, did participate in bereavement. For myself, when I came back to where I was living in the hospice I was working at, I did not really participate in the bereavement services now because I really had the support of my team. I had a really good social support. So I really had a lot of support around me that I didn't utilize that. But bereavement, and I don't know, for some hospices that they may offer some bereavement support to their staff. Some don't. Some people feel that they should get if you're an employee there, if you had a loss, maybe you should go outside of the hospice. There's a lot of debate on how to handle those situations. Right. Do you allow staff to come to bereavement support groups? I'm sure each hospice manages those, but there are EAP programs. Some hospices do work with local EAPs. That's an employee system program where you can go off site. So I don't know how, what your experience is on that end of offering staff bereavement.
My experience is really pretty similar, that each agency sort of manages it. I think the smaller mom and pops are maybe a little bit more hands-on in-house, and maybe a little more tightly bonded, depending on how long the team has been together, because there is something very intensely bonding about sharing these death experiences.
Yes.
Supporting patients and families. I don't know that we're always very good at bereavement care for our teams. I think it gets swept along with the busyness of doing things, the busyness of doing business, keeping up with visits and scheduling. And just like our CNAs, they may lose a couple of patients in one day, but they just get another couple of added on to their roster very quickly. And I don't know that we're always very good about remembering to take a deep breath and look at our team members as individual humans who grieve too. I think we forget to do that.
Yeah. In the old days, for all those out there, I'm sorry, that's the only way I could say it. There was a time in the old days where the hospice team went to the funerals. We went to funerals. I think I could write a book on funeral rituals. I mean, I've been to, Jewish funerals, people of color, all kinds of funerals, but that was part of the care plan. So it would be one of us went to a funeral, and I would go to a funeral with people I didn't even know who really which I didn't have a relationship. At the hospital would say, Melanie, Mrs. Smith's funeral is Saturday. You're on call. You have to go to this funeral. So I'd go to funerals. And it was such a wonderful, it sounds so strange, but the hospice team people out there, you'll understand. It was such a beautiful thing to go to a funeral, allow people to see you work for hospice, and they would be like, thank you so much. You guys came. You're so wonderful. It would be this whole thing. I know today no one really probably has time to go to funerals. It probably doesn't even happen, but there was a time. But that is a piece of finding closure and being part of something and really kind of just being there for the family in that next step.
Yeah, I agree. It seems that being able to have that sort of completion of the relationship for us on our side.
Yes.
To be able to go to a visitation or go to a funeral. I was never big on funerals. Not that I have any sort of aversion to it, but for me, as the nurse, being the nurse on the team, it was really important for me to be able to help that family understand that while we had shared this very intense experience and become very close through that, it was time to transition away from that, move away from a heavier or closer relationship with me to being closer to bereavement and closer to their own family and friends, because that season of their lives, caring for their loved one was over with. So for me, I always wanted to use it as an opportunity to say, thank you. It was such an honor to walk with you during this. And also it was great for me to hear the thank yous. It was very validating to hear that I had done a good job. Yeah.
Made a difference.
For them to be able to give voice to the respect and the value, the gratitude that they had for the care that I provided. That was always very important for me. But I do think it's important for teams to understand that that's a very sketchy transition time. And I think it's sort of a defining moment. Those caregivers, those family members need to be moving into the mode of bereavement. And sometimes they have trouble detaching. You've seen it. We do get caregivers that cannot disconnect from the clinical team, the nurses and the aides. And sometimes we do foster those relationships. We answer those phone calls when in fact that kind of counseling and bereavement is outside of our skill set. And it's something that should be handled by your bereavement and your counselors. I don't know that we're always that great at that.
No, and you're right. It is challenging. I mean, that's such a good point you brought up, Helen, because we know we have 5 more families that need us over here. And
Always.
If we spend time over here in bereavement, then we're burning ourselves. There it comes back to that self-care. How do you balance handing it over, saying thank you, allowing them for letting me be in this? It's such an intimate experience to be with somebody as they die. To transition to this person that's in bereavement who they don't even know, and they're like, we don't want Melanie. So, it is a delicate it's a balance, and it's challenging because you have to shift here and you have other families that will, deserve the same experience and the same care. But if you're always over here, you're not going to be able to shift here.
Right. And you want to honor the relationship that you've had, but they have to transition away from that because that part of the care plan is complete.
Yes.
With the death of the patient. So, yeah, like I said, this could be a month's worth of conversation. That's hilarious. Okay, so Melanie, let's take the $10 million question. What would be on your wish list for end-of-life care? I can hear the wheels spinning.
I think it's interesting because that's an interesting question because you mentioned it earlier, there's so much of how the hospice benefit was created that I feel it is already perfect if we do it and we use it the way it's supposed to be. I mean, obviously my wish list is that we weren't regulated, that we didn't have.
Oh my gosh.
Back before when the volunteers did hospice, they had a hard time staying open, but the Medicare benefit it afforded us to have income. So I understand how that is important too. But I feel like if we get back to using all of the discipline in a way that everyone feels heard, everyone's used to their best skill set, it's already a fine-tuned wheel.
It is. It is one of the most amazing, unique models inside modern healthcare. Mm-hmm. I agree. So that would be on your wish list, that every discipline be utilized to their very fullest. I love it. Mm-hmm. I love it. Melanie, you are so generous to sit and share your wisdom from years of experience. I'm so grateful for the conversation today. Thank you so much.
Me too. I'm so happy to be here. And anytime you need a fill-in, I'm available.
Thanks. You can see that Melanie has really witnessed a lot of changes to the hospice industry. She remembers when NHPCO, the national organization, was the NHO, National Hospice Organization, and when they didn't want to involve palliative care. They didn't like the name, which of course palliative care is always part of hospice, but now it's its own specialty as well. So she's seen a lot of change, a lot of growth in the hospice industry. She knows the value of the interdisciplinary team approach and how every one of those disciplines brings value to the care of the patient. One of the things that Melanie mentioned that didn't surprise me, but I thought it was a really good point, was that every person on the interdisciplinary team needs to stay close to the team to be able to receive that support, because that's how we get through our days. It really is. Hospice team members, a lot of times, end-of-life workers, they don't go home and unload all that information on their families. For a lot of family members, I know my family personally could never relate to the work that I did during the day. I don't know that I wanted them to, because we see and hear things that are very difficult to witness. To watch other people suffering is very hard. And then to be able to express it to someone who has no contact with that kind of work, I think it's overwhelming for the hospice professionals, but I think also not everybody's able to receive that information. So I never shared a lot of the things that I saw with my family when I was working at the bedside. So Melanie's right. Staying close to your team and supporting them and receiving support is really, really important. Having those memorial moments with the team to remember the patients that have died, that's a great way to provide bereavement care. It's not bereavement services. That's what we provide to our families of our patients. Bereavement care, where we look after each other. We keep each other emotionally healthy. Hospice professionals are just as inept sometimes, just as dysfunctional as anybody else when it comes to managing personal loss. And interestingly enough, Melanie found that working in hospice helped her find meaning in her own grief and loss, first with the loss of her mom and then the loss of her dad. She gave us a good reminder that there are many ways to serve in hospice. And if you have had an experience or you find yourself experiencing secondary grief or overly identifying with a patient or family, it's okay to say, this is not a good place for me to work in anymore. I need to be in a different space. You can still stay inside end-of-life care. If your agency is willing and adept enough, you can be, forgive the business-like word, the mechanical word, but repurposed to be able to work in a different section that's a better fit. And isn't that a better way of conserving our resources, our human resources that we have in hospice, rather than churning and burning out our staff members and just letting them move out of the industry completely, taking their skills and their experience and their wisdom with them? Isn't it a better thing to encourage them, find them another place, and help them move forward inside hospice, still working and sharing their gifts? That's what I think is better. She also brought up what she used to do about attending funerals. And she said way back when we were taking call and she was volunteering, well, when we had volunteers that were working, they would go to those funerals. And she feels like there are advantages to doing that. I do too. I think there's some completion of the relationship, and Melanie even used the word closure. I also think it's important to balance that personal presence at funerals and visitations with our own personal and professional boundaries. Super important for us to maintain those for our own mental, physical, emotional, and spiritual health, and our professional health as well. So, a great conversation with Melanie McMillion. Be sure to catch the next episode of the Heart of Hospice podcast. You can find more episodes on theheartofhospice.com. Don't forget to subscribe on your favorite podcast platform. You can connect with the Heart of Hospice on Facebook and Instagram, and send your questions or comments to me by email at helen@theheartofhospice.com. And remember, no matter who you are or where you are in your hospice journey, you are the heart of hospice.
This is the Whole Care Network. Helping you tell your story one podcast at a time.